Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
More and more people are surviving lung cancer. In fact, from 2016 to 2017, the U.S. saw its largest ever single-year drop in overall cancer deaths, and it is largely credited to improvements in lung cancer detection, diagnosis, and treatment. There have been more lung cancer treatment advances in the last 5 years than in the last 50 years. Still, lung cancer remains the leading cause of cancer death, and we must do more. At the University of Kansas Cancer Center, scientists are looking at immuno-based and targeted therapies to further boost lung cancer survival rates. Good morning. I'm Dr. Roy Jensen, director of the University of Kansas Cancer Center. And with me is Dr. Jun Zhang, a physician scientist who studies lung cancer. And also joining us is Michelle Hills, a stage 4 ALK or ALK positive lung cancer survivor. And Megan Peters is here to take your questions. So first of all, welcome, Michelle. Could you please tell our audience about your lung cancer experience?
Thank you, Dr. Jensen, and thank you for having me here. You know, this summer of 2018 was a really difficult one for me. I was an executive at a pharmaceutical company, a competitive athlete in an active training program, when a persistent cough set in June. I went to see my PCP and I was diagnosed with allergies, but over the course of the summer, my cough increasingly worsened. So I went on to see some other doctors where I received all kinds of different diagnoses, from sinus infections to acid reflux. You know, I saw about 5 physicians over the course of 12 appointments in 3 different health systems before I was admitted for pneumonia, and to everyone's surprise, I was discharged with a lung cancer diagnosis, which came as a complete shock since I had never smoked before and I had no known risk factors for lung cancer. I was correctly diagnosed at the University of Kansas Cancer Center, and shortly after that, I set out to find some support for myself because I really felt fairly isolated, having never been a smoker and learning about the stigma of lung cancer. So I reached out to the American Lung Association, where they told me about the Lung Force program, and I learned about the funding mechanisms for lung cancer and was absolutely shocked to find out how underfunded lung cancer is relative to other cancers, and was given an opportunity to start doing some advocacy work to lobby Congress to increase the funding for NIH and lung cancer research. And more importantly, they introduced me to a woman whose story was very much like mine. And together with the support of KU Cancer Center and the American Lung Association, we launched Kansas City's first Living with Lung Cancer support group at the University of Kansas Cancer Center. And so from there on, I have been a strong advocate and voice for the lung cancer community, and I'm delighted to be here.
Wow, that is quite a story. You certainly seem to stay quite busy. Now, one of the activities that you mentioned was that you helped serve on our Cancer Center's Community Advisory Board. And how does that board in particular support our efforts in the Cancer Center?
You know, it is an honor, Dr. Jensen, to serve on the Community Advisory Board. Long ago, I trained as a licensed clinical social worker, where I was on the front line of the healthcare delivery system in Newark, New Jersey, where I saw the disparities of healthcare. And I learned that zip code matters, and it really shouldn't, but having access to good quality care directly influences the clinical outcomes for patients. So my role in the Community Advisory Board is to, one, serve as a voice for lung cancer patients in the Kansas City area so that we can drive improvements in the healthcare delivery system, and two, educate the community about lung cancer. About 90% of lung cancers, like myself, are diagnosed at stage 4 because there are no screening criteria for never smokers, and physicians in the community really aren't well trained beyond a Harvard checklist to go beyond um, the diagnostics of looking at a persistent cough. So if we can help improve the screening criteria in the community, early detection is really critical to surviving this disease.
Thanks, an extremely important point. So now I want to turn our attention to Dr. Zhang, and what really led you to focus your clinical efforts and your research efforts on lung cancer, Dr. Zhang?
Thank you, Dr. Jensen. It's an honor for me to be here with you today. There are a couple of reasons for me to actually pick lung cancer as my focus in both the clinical practice as well as research. Number one is, when I was a medical student, I was always amazed by those beautiful organs in our body. And I think, lung cancer is one of them. In fact, I consider lung is the organ that of inspiration. And also, before I became a thoracic oncologist, I had early exposure about lung cancer during my early career. I was trained as a pulmonologist back in China. The health system is kind of a little different. Over there, the organ-specific cancer normally managed by organ-specific specialists. So lung cancer is basically managed by a pulmonologist. And this early exposure kind of built up affinity for me to this type of disease. And third is, we know that for us to understand lung cancer well, we have to have a good animal model. So my PhD training as well as postdoc training, in fact, led me to kind of master a series of essential skills so I can build and apply those very delicate, sophisticated animal models for me to study lung cancer. Now, considering lung cancer is the #1 killer, cancer killer for both men and women worldwide, I think my experience in both the clinical side as well as research really made me to decide to choose lung cancer as my focus.
So you mentioned at one point in your training you received a PhD. Could you tell us a little more about your journey to become a physician scientist focusing on this disease?
Sure. It's always easy to put these two words together, physician and scientist together, but in reality, it actually requires lots of training. And I know that Dr. Jensen yourself is also a physician scientist, so we know that. When I was a pulmonologist back in China, that was many years ago, we don't even have a target therapy, we don't have immunotherapy. So at that moment, we are basically treating, smokers' lung cancer versus non-smokers' lung cancer in the same way. And after witnessing lots of people actually died from this intractable disease, I kind of gradually built up my strong desire trying to understand this disease well. And that was the reason that I came to this country to pursue a PhD degree, and followed by a couple of years of postdoc training, trying to really understand the disease well so I can apply the knowledge to benefit our patients. And we know that physician scientists, some of the authors say that it is the kind of endangered species, in the population of physicians. In fact, it represents probably less than 2% of the total physician population. We are kind of drawn to the clinical needs and challenges of the patients, but at the same time, we're also drawn to the opportunities that we can have some scientific discoveries based on patients' clinical problems, so we can kind of benefit them. And so therefore, going back and forth between the clinic and the science, the bedside, to the bench side as kind of really essential and natural part of this job.
So, Dr. Zhang, you study a very interesting aspect of lung cancer, and it has to do with the human microbiome. Could you tell us, first of all, what is the microbiome, and how does that relate to lung cancer?
Yeah, so a microbiome, this is in fact one of our research interests in the lab. So the term of microbiome basically is to describe a collection or aggregates of those microorganisms, including virus, bacteria, and fungi. And in our lab, we are primarily focused on the bacteria. So we know that those microorganisms are in fact essential to educate our immune system. Therefore, there's no surprising to me that they can affect our health status, affect the cancer initiation, progression, as well as our treatment to lung cancer. And in fact, before we actually start this project, there are already some data suggests that the role of microbiome in cancer immunotherapy. But what we are trying to understand in lung cancer, particularly, was number one was trying to understand whether those microorganisms, from different body sites, especially, for example, in the nasal and buccal area, because they're kind of closely related to our lungs, as well as from the gut, can really, predict the treatment response of lung cancer patients receiving immunotherapy. At the same time, also want to know whether or not this microbiome can have the association or predictive value for patients on immunotherapy that develop what we call immunotherapy-mediated toxicities. And this is clinically quite important. We know that everybody knows that immunotherapy is important, is valid, but at the same time, occasionally we lose patients from serious side effects induced by immunotherapy. So this is a key element that we need to understand in a clinical setting. And number three is, of course, we are trying to understand the mechanisms. I mean, there are studies, people know that the microbiome in the gut is important for the development of colon cancer. It makes perfect sense because, it's in the gut. But how does the microbiome in the gut, for example, affect remotely the lung cancer, especially lung cancer treatment? It is still kind of unknown area. So we are trying to explain, trying to re-explore the mechanism behind that. And finally, as we know that there's lots of important modulating factors of microbiome, for example, our diet, the antibiotics that we use in a clinical setting, whether or not they can affect treatment. This is also important for us to explore.
Well, that's really interesting, and it's fascinating that the microbiome could have those potential impacts. So, believe it or not, this is not the first time that we've heard the term microbiome on this show. And prior to this, we actually had a discussion about colorectal cancer, and that's pretty obvious association there. But we've never really considered the impact that the microbiome could have on lung cancer. So, perhaps you could tell us what are some of the theories around how the microbiome could influence a person getting cancer in the first place.
Yeah, sure. So we know that gut microbiome is important, but also nowadays people find that the local microbiota, especially like the local, when we say local means that those microbiota in the respiratory tract, and seems to be also influencing the lung cancer carcinogenesis and progression. And one of the very strong evidence, in fact, was from a very delicate mouse model, which we call genetically engineered mouse model. And from that model, Dr. Tyler Jack's lab, what they did was they can actually turn on certain genes that activate lung cancer. And what they found is if you give, for example, those mice antibiotics and then turn on those genes, their speed or their the speed to develop lung cancer is much slowed, and at the same time there's less tumor burdens in the lungs as well. And quite interestingly, then they actually harvest those bacteria from those mice already developed lung cancer, and then implant to those germ-free mice, and those mice also develop lung cancer. So this is kind of clear evidence showing that the local microbiota does play a cost-effective role over there. And there, with the more in-depth studies, what they found is those local microbiota, in fact, can cause inflammation. And we know that, inflammation, it could be something trigger, in fact, the carcinogenesis. And local inflammation, has already been shown that can initiate lung cancer. So this is kind of the piece there from the lab setting. And what we found is we actually have a cohort of lung cancer patients that before they start with immunotherapy, we harvested their microbiome specimen from the nasal swab, the buccal swab, as well as from stool samples. And then we also collected the second set at the time when they developed, for example, the immunotherapy-mediated toxicities. And then we collected the third set at a time when those toxicities get resolved. And kind of quite interesting, what we found is not only the gut microbiome, but also the microbiome from nasal and buccal area kind of correlate very well to their treatment response, as well as immune-mediated toxicities. And one way for us to monitor the health condition of the microbiome is the diversity. And what we notice is for those patients, at the time when they develop immune-mediated toxicities, the diversity is not only in the gut, but also in the nasal and buccal area, the diversity gets lost. And at the time when those patients recover from immunotherapy-mediated toxicities, they regain those bacterial diversity. So suggesting that from the animal part, we know that there is cost-effective value, but then from a clinical side, suggesting that it may also have some predictive value. And based on this study, we're actually in the process of building a model so that can be validated in my other 2 clinical trials, and hopefully someday we can introduce to clinical practice.
That's fascinating. Megan, I understand we have our first audience question.
Yes, we do. So the first question is, are the side effects cytokine storm?
Yeah, this is a good question. I mean, cytokine is certainly one spectrum of the side effects of immunotherapy. And cytokine storm normally represent those most severe and serious case of side effects. But when we are talking about side effects from immunotherapy, in fact, one of the best way for us to grade those side effects is by using the clinical trial CTCAE scale. And we actually have 0 to 5 scale. 0 means no side effects at all. 5 means like so severe the patient actually die. So most often, I would say from immunotherapy, the side effects is pretty mild. In other words, grade 1 to 2. And this accounts for probably about more than 50% of patients. They will experience certain degrees of mild side effects, grade 1 to 2. But then about 3 to 5% of patients will develop serious side effects, grade 3 plus. And some of them, for example, pneumonitis, and could be a life-threatening situation. And if it really affects multi-organ, then most often this is also linked closely to cytokine storm.
Thanks. So it sounds like we have another question, Megan.
We do. We actually have 2 questions that are related to each other about the microbiome. The first is, what are some ways that we can create a healthier microbiome and microorganisms in our body? And then related to that, can you change your microbiome by what you eat?
Yeah, those are excellent questions. So Megan, actually, I get lost of your second part of the question, but I guess I can start with the first one first. So we know that microbiome is important, but there's many ways. I always think 2 major ways to modulate our microbiomes. One, we know that is a diet, and diet is probably the most important thing. Now, at this moment, we don't have a strong evidence to say which diet is the best, but there is one, in fact, one study from MD Anderson. They published in an abstract format, not yet in the full publication. And they were actually studying melanoma patients. And what they found is for those patients with a higher ingestion of fiber-based diet, there is basically have increased diversity in their gut microbiome, and correspondingly, they have better response to immunotherapy. Now, whether or not this is the same situation happened to our lung cancer patients, we do not know, and that's why I am actively studying this project. I'm working with our nutritionist like Dr. Deborah Sullivan, Dr. Joe Hamilton, and also with the microbiome expert like Dr. Shahid Omar, and we're trying to really to see whether or not in lung cancer patients as well that diet play an important role. In fact, we have an investigator-initiated clinical trials, and we are for those lung cancer patients who are receiving single agent immunotherapy. Not only we plan to collect their microbiome from different body sites as we did before, we also ask them to basically take a very detailed diet survey. So from there, we can actually get information about their diet details, their diet pattern, and to see whether or not certain diets, in fact, number one, relating to gut microbiome and microbiome from other body sites, and number two, whether or not certain diet in fact also correlate to treatment response as well as toxicities from immunotherapy.
So if you're just joining us, we're here with physician scientist Dr. Jun Zhang and lung cancer survivor Michelle Hills. And Megan Peters is joining us via Skype and taking your questions. Remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. So first, Dr. Zhang and then Michelle, what would you say you are most excited about in lung cancer treatment and research? Dr. Zhang, you first.
Sure. So I've been involved in this area for many, many years. And as I mentioned before, that decades ago, I would say probably 20 years ago, we treat basically smokers' lung cancer versus non-smokers' lung cancer in the same way. But now we have very different approaches to tackle this disease. I mean, we see a higher cure rate for those patients with early disease, even with advanced localized disease. We certainly have more approaches for those patients with metastatic lung cancer, including targeted therapy and immunotherapy. And we also know that we kind of learned that cancer is a very personal disease. I mean, my lung cancer versus your lung cancer is, despite we are using the same term, when we look into the molecular level, they are quite different. And when we look at their immune profiling, they are also different as well. And I think, Michelle's story is a perfect illustration that how important and successful a personalized therapy can be. And I think, with all this explosion of our knowledge in this field, as well as cutting edge technologies, I really believe that we're going to have more and more innovative ways to treat this type of disease.
Thanks. Michelle?
Yes, thank you. The ALK Positives have created a patient foundation called alkpositive.org. And together they've raised nearly $2 million to support lung cancer research for ALK positive patients like myself. One of the most promising projects that's coming out of the Massachusetts General Hospital is new forms of immunotherapy for ALK positive lung cancer in the form of a vaccine. For some reason, those patients who have ALK positive lung cancer aren't good candidates for immunotherapies like Keytruda. So we are looking for alternate pathways above and beyond the targeted therapies. And later this year, there will be a phase 1 first-in-human clinical trial out of MGH to support the ALEX vaccine, which can really blow the door open for long-term survival rates in ALK-positive lung cancer patients.
That sounds great, Michelle. So before we close out, Dr. Zhang, could you just tell us a little bit about the importance of molecular testing in regards to the selection of lung cancer treatment? And I think Michelle's case is a fantastic example of that very phenomenon. But please go ahead.
Yeah, sure. As I said, well, if we look at the molecular level, their molecular pattern, in fact, can be very much changed by our exposures, the environmental factors. And especially for those non-smokers, we know that they actually have high chance to have those what we call targetable mutations. And we know that especially for the adenocarcinoma of non-small cell lung cancer category, like Michelle's case, that if we can combine two approaches, one we call tissue biopsy, meaning that we actually get a piece of tissue from the tumor, and the second is liquid biopsy, meaning that we get a tube of blood from patient and then extract the DNA from there. And by combining them together, we now can have the highest odds of finding those patients having those targetable mutations. Means that there's one particular defect in the gene that driving the initiation and progression of that particular type of cancer, so that if we target that particular gene, it will be a very effective approach to kill cancer. In fact, when you combine these two approaches together, we can have up to 40% of the patients can have the chance to find those mutations. We have the success for cases for those patients with EGFR, which is about a quarter of the lung adenocarcinoma patients. We have success story for ALK mutation, like Michelle's case, which is about 2 to 4%. And now we have, at this moment, we have about 7 mutations that are eligible for target therapy that is approved by FDA. In addition, we have some other mutations, for example, KRAS mutations, which is closely related to smoking. We have HER2 mutations that not yet get FDA approval, but we have very exciting clinical trials ongoing. In fact, in our institutions, we have clinical trials for both KRAS mutant non-small cell lung cancer, as well as for HER2 mutant non-small cell lung cancer patients. That's why it is so important. Now, at the same time, we are also trying to really optimize immunotherapy and some other combinations. Some of them we know that they're not that particularly effective, for example, for EGFR mutant non-small cell lung cancer patients. But this is only using the current immunotherapy. We may have a better or novel approach in the future using different immunotherapy in the future. So to conclude, I would say that it is very important for us to understand the mutation status because of the high chance of finding those mutations, and also because of the high response rate for those target therapy. As we know that almost 72%, more than 70% of patients will be responding to those target therapies. And with this response with a good quality of life, as we can see from Michelle's case, it is the most important thing for us in the clinical setting.
Well, that's fantastic that so much progress has been made of late. Megan, it looks like we have another question.
We do. Kathy would like to know, are you involved in the CAR T cell research?
Not for me particularly, but we actually have a very strong cell therapy team. Now, CAR T therapy is quite effective, especially in those what we call liquid malignancy or leukemia patients. Not that quite successful in solid tumors. But having said this, there's already interesting data to recommend, to suggest that this will be another innovative approach. There are one of the molecules I'm actually studying, which is called ROR1, and in fact, people are already developing CAR T therapies for lung cancer patients harboring this particular mutation. And we know that there's also good data for example, for GBM as well. In fact, in my lab, next to my lab, Dr. David Ackerman's lab, they're actively studying CAR-T therapy for solid tumors, and hope he will have a chance to give you more information next time.
All right. It looks like we have another question, Megan.
We do. There is a question asking what kind of lifestyle services or support services does the Cancer Center offer to do things like nutrition, exercise, and things like that?
Yeah, I do aware that we have a very good support for that. I'm glad actually you mentioned about these two things. Like nutrition, as we mentioned earlier, it's not only kind of relevant to my research topic, which is microbiome, but also we know that for cancer patients, especially lung cancer patients at the late stage, they're quite often they have malnutrition, and we know that adequate calorie and balanced diet is so important for our immune system. And the same thing for the exercise, and there's enough data to show that exercise, in fact, can activate immune system. And also, there's interesting data not only in the preclinical but also clinical side that exercise can not only enhance the treatment response from our conventional treatment, but also help to fight against toxicity, side effects from treatment, and in fact also prevent cancer's relapse. So based on that, we actually have a good team for that. We have a dedicated team from nutrition side. We have a dedicated team for exercise. As I mentioned earlier, that one of my collaborator, Dr. Joe Hamilton's laboratory, is basically integrate not only both the nutrition and as well as exercise for patients for patients with various types of cancer, and we hope that we can have her expertise to be introduced for our lung cancer patients as well.
Fantastic. So we are close to the end of today's episode, and Michelle, I want to give you the last word here. What advice do you have for those who have just been diagnosed with lung cancer?
That's a great question. I think I would say trust your instinct. If something doesn't feel right or you're not comfortable with the recommendations that are being made by your physician, certainly take advantage of a second opinion. And in some cases, it's becoming increasingly more common to receive a third opinion because the science is advancing so fast that community oncologists simply cannot keep up with the pace of scientific development. So it's really important to get an accurate diagnosis through biomarker testing, make sure it's comprehensive. Not every cancer physician tests for all of the targetable mutations. So you really need to make sure you get this comprehensive biomarker test done for personalized treatment. And know that science is on your side. Stay away from Dr. Google. Stay hopeful because there are people like me out there living with this disease quite successfully. And secondly, I would say that you're not alone if you're newly diagnosed. There are resources available. We have a Living with Lung Cancer support group that meets at the Cancer Center via Zoom. But there are larger, more national patient organizations like Longevity and the GO2 Foundation that can serve as a wealth of information to help translate the complexities of managing lung cancer. A friend of mine said to me that being diagnosed with lung cancer is like being abandoned in a foreign country without a translator and a map. So those national resources can really help educate you to ask good questions of your doctor so that you can feel comfortable with your treatment team, because the bottom line is that anybody with lungs can get lung cancer, and informed patients live longer.
Well, what a fantastic message to end our segment on here. And very much appreciate you coming on our show, and thank you as well, Dr. Zhang, for being part of this week's episode of Bench to Bedside. To learn more about lung cancer, please visit kucancercenter.org/lung cancer. That's it for today. Join us next week at 10 a.m. for Bench to Bedside. Thanks for watching.